So thank you all very much. Thanks for coming back from your lunchtime break. And as I was thinking about this topic, I have to say it brought back some memories for me about my internship in Chicago at Children's Memorial Hospital. And my first assignment was in the newborn ICU. And my senior resident, who I remember very well, who came up to me and said, "Rich, you have a baby with sepsis to work up." I said, "Wow, that's really cool. What do I do?" And he said, "Well, give the baby penicillin and kanamycin and some IV fluids, and baby should be fine." And I did that. It took me about an hour to get the IV started and to get the orders written. And then after the hour, my senior resident comes to me and says, "Rich, you have a baby with sepsis to work up." I said, "Okay, I know what to do." And it took me another hour. And as the day went on, I must have admitted 8 or 10 babies, all with that same diagnosis of rule-out sepsis, all of them which looked pretty good to me. And after a while, I guess I have become less enamored with the diagnosis of sepsis. I've written those words, rule-out sepsis, probably 10,000 times in my career. And like most of you in the audience, I've learned how to hate that diagnosis. So I'd like to start off by giving you the top 5 reasons for hating the workup for neonatal sepsis. These are my own. So number 1, there's no glory in performing a sepsis workup. So nobody goes to you and say, "That was a great sepsis workup." Nobody cares. And as you all know, most rule-outs occur between the hours of 2 a.m. and 5 a.m. when everybody's asleep. Drawing a blood culture from a preterm baby at 24 weeks is like drawing blood from a worm that has tiny veins. Even when the blood culture is negative, everybody usually ignores the results and treats the baby for 7 to 10 days. Nobody cares about the results of cultures. And finally, and this happens at Columbia, the probability that the lab will lose the blood specimen is inversely proportional to how difficult it was to draw the blood and how critical the specimen is. So, and maybe you have some of the same experiences as I do. So I have 3 sort of objectives for this talk. One, I'm going to spend a little bit of time talking about the importance of chorioamnionitis in the pathophysiology of sepsis in babies, to highlight some of the controversies surrounding that diagnosis, and then in the sort of the last half to present to you a scientific rationale for the diagnosis and management of babies at risk for sepsis. These are the most recent data from the US. There's an article published about 3 or 4 months ago. And there, in the US, a little over 3,000 invasive, proven early-onset sepsis cases. Obviously, rule-out sepsis is a much larger denominator. About 10% of those babies die in the US each year, about 400 deaths. Overall, group B streptococcus is still our leading pathogen, with E. coli second, except if you are a preterm baby in the US, E. coli becomes number 1 and group B strep number 2. And like I'm sure here, about 2/3 of our isolates are resistant to ampicillin. And the rate of sepsis varies tremendously with the ethnic background of the patient and the gestational age. So the highest rate is in Black preterm infants with a rate or an incidence of about 5 per 1,000 live births. The lowest in non-Black infants born at term with an incidence of only 0.04 per 1,000. But the case fatality ratio does not vary with ethnic background. It's still about 25% among preterm babies. It's still extraordinarily high, and less than 2% in term babies. So let me give you a little case. This is the first pregnancy for a 22-year-old woman with an unremarkable pre-pregnancy history. At about 27 weeks gestation, a membrane's rupture at 2 p.m. She comes into the hospital at 12 noon the following day, so almost 24 hours later, because of painful uterine contractions. They do a rapid nucleic acid amplification test to detect group B streptococcus. In the US, that's being more and more frequently used on women that may be culture positive. Following placement of the epidural, she develops a temperature of 38 degrees centigrade. There is no uterine tenderness, and her white blood count is normal. The care providers debated whether to use broad-spectrum antibiotics because of possible chorioamnionitis because of the fever, or just penicillin for prophylaxis against group B strep. So if you think about it, there are really 4 ways babies can get infected before birth. 2 of them are rare, fortunately, and 2 of them are a little more common. One is retrograde infection from the mother's abdominal cavity, extraordinarily rare. Mother has to have peritonitis. Second rare is introduction of infection via amniocentesis. Fortunately, the incidence is very, very low. The last 2 ways I said are more common. One is transplacental infection, and as you know, these are all the chronic congenital infections, syphilis, toxoplasmosis, CMV, etc., that are transmitted transplacentally. But by far the most common way that babies become infected is an ascending infection, and as you know, chorioamnionitis is a key step in this pathway of newborn infection. But there are really 2 different kinds of chorioamnionitis. This lecture, dealing with early-onset sepsis, is going to focus on the acute chorioamnionitis, the woman who's acutely symptomatic, who's febrile with uterine tenderness, cloudy or foul-smelling amniotic fluid, and after a while it becomes obvious that's what we're dealing with. The other variety is potentially more significant for the newborn baby, especially the preterm baby, and this is the subclinical chorioamnionitis, where the woman says, I feel totally well. It may be in the first trimester of pregnancy when this kind of infection is established. It usually begins as a choriodeciduitis, sort of shown over here, and a little under high power over here. And from that site, at least the theory that's been put out there, is that inflammatory mediators can get into the baby's circulation, the fetus's circulation, and result in the sequelae of either chronic lung disease or periventricular leukomalacia. So contrasting the 2, the subclinical chorioamnionitis may be a completely asymptomatic woman, or she may go into preterm labor. These are the kinds of pathogens recovered from women with subclinical chorioamnionitis, ureaplasma, mycoplasma, Gardnerella. The symptoms may be variable at birth. The baby may look totally well or may have a non-infectious disease like RDS. And the worry, or the association at least, is with brain injury in babies, PVL, and chronic lung disease. And let me point out that these kinds of infections are probably way more common than those that cause early onset sepsis in babies, because in several studies now, where they've taken cultures from the baby from the cord blood or immediately after birth, about 25% of babies, less than 1,500 grams, are bacteremic either with ureaplasma or mycoplasma. So it's probably the most common infection we see at birth. What you do with it, I'm not sure anybody knows, but it's a common infection. The other variety, as I've already told you, is a symptomatic mother, and these are the kinds of pathogens, group E. streptococcus and E. coli, often leading to fulminant sepsis at birth with cardiovascular instability and respiratory distress. So a key question, if chorio is so important, how do we define it? This looks at the variety of ways that obstetricians are faced with when in making the diagnosis of chorio. The easiest way, and the one we most relate to, is clinical chorioamnionitis, the woman who has fever or tachycardia, a vaginal discharge, uterine tenderness, fetal tachycardia, cloudy or foul-smelling amniotic fluid. All that goes under the rubric of clinical chorioamnionitis. The other way we sort of hear about after the fact from pathologists is histologic chorioamnionitis. And it would be nice if the clinical and histologic chorioamnionitis correlated with one another, but they do not. Histologic chorioamnionitis is 3 times more common than clinical chorioamnionitis. And in only about 2/3 of the time when this diagnosis is made, is there any evidence of histologic chorioamnionitis. So there's a poor correlation. The other ways that are sometimes used more as an investigational tool is looking for biochemical evidence of chorio. People measure cytokines in amniotic fluid, and those correlate actually very well with something called microbial invasion of the amniotic cavity, sometimes abbreviated MIAC, in which the obstetrician gets a positive culture out of the amniotic cavity. But you should know that only about 10% of the time, when you can culture a pathogen out of the amniotic cavity, is there actually a baby who has sepsis. So there's not a good correlation with any of these and clinical or proven sepsis in newborn babies. Another way of looking at it is sort of this Venn diagram I put together a few months ago. And the broad group of women have no chorioamnionitis. And then the next most largest group are women that have histologic chorioamnionitis and are usually not symptomatic. But again, the concern is this may result in preterm premature rupture of membranes or preterm birth or possibly cause neonatal morbidity such as PVL or chronic lung disease. A much smaller segment have clinical chorioamnionitis, and then again, a much smaller segment of those end up having neonatal sepsis. These are data from the NICHD network published about a year and a half ago, which looks at those relationships between histologic chorioamnionitis, clinical chorioamnionitis, and early onset sepsis in babies, and it's looking at our preterm population, 22 through 28 weeks gestation. And if you go across the board, it's clear that histologic and clinical chorioamnionitis, and in fact sepsis, are all more common in babies who are more immature, and that the relationship between histologic and clinical chorioamnionitis is about a 3-to-1 relationship. In other words, histologic chorioamnionitis, again, is about 3 times as common as clinical chorioamnionitis in women. If you look at the lower limits or the lowest limit of viability in some centers, which is 22 weeks gestation, about 1/4 of all babies born to women with clinical chorioamnionitis develop early onset sepsis. And if you look at 28 weeks gestation, the ratio is about 1 out of 14, or about 6 or 7%. The diagnosis of chorioamnionitis is problematic for the obstetrician. Again, many women are completely asymptomatic, having had chorio for weeks until the membranes rupture or they develop preterm labor. The clinical diagnosis is often inaccurate, and obstetricians often say the woman is febrile, therefore she must have chorioamnionitis. That's problematic for all of us because many of the guidelines, in fact our own guidelines I'm going to show you, say that if that diagnosis is made, that's a mandatory indication to treat a baby for possible sepsis. So the diagnosis of chorioamnionitis carries a lot of significance. Obstetricians have looked at white cell values in amniotic fluid, again, inflammatory mediators, lowered glucose concentrations, but all of those are relatively inaccurate. But I'd like to bring you aware or make you aware of another approach to the diagnosis, and that is using proteomic profiling in amniotic fluid. In fact, they're also looking at women's serum. Proteomic profiling, as the name suggests, is looking for patterns of protein in amniotic fluid which are suggestive of infection. Most of the proteomic platforms use a variety of technologies, and the one we're going to talk about uses chromatography with mass spectrometry. And the leader in that field is based at Yale, New Haven, at Yale University. It's Irina Buhimsky, and she's defined 4 proteins found in amniotic fluid. 2 of them are defensins, 2 of them are called calgranulins. They're all derivatives of white blood cells that correlate strongly with chorioamnionitis and also with newborn infection. And when she measures these, she developed a score. She calls it a mass-restricted score. So if none of the 4 proteins are there, the mass-restricted score is going to be 0. If 2 proteins are there, like here and here, is a score of 2. When all 4 proteins are present, the amniotic fluid has a score of 4. And interestingly, there's a fixed sequence of appearance of the proteins in amniotic fluid. First the defensins, 2 and 1, then calgranulin C and calgranulin A. And these are some of her data. She has even a more recent publication, which has come out in the past several months, looking at the relationship between that score, that mass-restricted score, and the degrees of chorioamnionitis. So we're looking over here at stages of chorioamnionitis, showing the stages go up with higher mass-restricted score. The same is true for choriodeciduitis, and the same is true for amnionitis. And of relevance to the newborn baby, she's also correlated that score with the presence of phenocitis and risk of sepsis. So in this study that she did, published in 2007, in women, neither the white blood count nor PPROM correlated with the presence of phenocitis. Calgranulin C, and if we go back, let me just go back a couple of slides. if I can, here we go. Calgranulin C correlated most with phenocytis. Remember, that's the third to appear in sequence. And calgranulin A, which is the last to appear, was most predictive of sepsis. So it's not just the score itself, it's the sequence of appearance that can tell you the likelihood of a baby being infected. And I think that's the future, is going to be the use of proteomics to make this diagnosis. So our baby, in this case history, is delivered at 29 weeks, following rupture of membranes for about 22 hours. They gave intrapartum antibiotics, which was ampicillin and erythromycin, which is the combination given most frequently in the United States for women with PPROM. The baby was suctioned and dried by the nurse, and because the baby's at Columbia, we just put the baby on nasal prong CPAP. APGAR scores were 6 and 8, and he exhibited some mild respiratory distress. And there's our baby. He's unhappy because he didn't like being in our NICU, but that's the sad part. So how should the workup proceed? So for me, I ask myself, when I see a baby like this, I ask myself two questions. Is this a symptomatic baby? And in most cases, if the symptoms persist, that's a baby who's going to need treatment, or asymptomatic. And are there risk factors for sepsis present in the mother's history or not? And if I ask you, we probably all use the same approach to sepsis. We look at the antenatal risk factors, we perform a careful examination, and make some sort of an estimate or the probability of sepsis based on the signs and history. We order some lab tests and cultures, which I'm sure vary from site to site. And finally, we decide who needs antibiotics based on the above information. And for me, it's sort of attaining a threshold for treatment. Let me show you what I mean. So starting with a baby in the NICU, if they're critically ill and they are symptomatic, that's sort of a no-brainer for all of us. We're going to end up treating that baby. On the other hand, when it's an asymptomatic baby who looks well to you, and I'm not specifying gestational age here, but there are risk factors present. I say, what risk factors are present? If it's chorioamnionitis, and we can debate how you make that diagnosis, that for me suggests mandatory treatment with antibiotics. If there are other risk factors, for example, prolonged rupture of membranes more than 18 hours, which is clearly a risk factor for sepsis, then we often do diagnostic testing. If it's abnormal, we may end up treating the baby. If it's normal, we may end up just continuing to observe that baby because they're asymptomatic. But there's also another group, a group of babies who don't look so sick. It's probably the largest group, who don't have risk factors for infection. And in those babies, my recommendation is you watch those babies, because in lots of babies who are undergoing a transition to postnatal life, by 4 or 6 hours of life, they may turn from a baby who's symptomatic to a baby who's completely asymptomatic. If symptoms are persistent, then you do diagnostic testing. Again, if it's abnormal, that might force your hand to treat, and if it's normal, usually no treatment. This is the old-fashioned way of looking at risk factors for sepsis. It's the way that I did for most of my professional career. For example, prolonged rupture membranes for more than 18 hours. They say the incidence of sepsis is about 1%. If you start to get prolonged rupture membranes and a preterm baby, the risk may go up to 4 to 6%, or accompanied by low APGAR score, the literature is 3 to 4%. The highest risk category is chorioamnionitis, especially in a mother who's colonized with group B streptococcus. But as I said, this is the old-fashioned way of looking at it. Late in 2011, Karen Pupolo from New York published this paper, which I think is an important paper, and it really will describe, I think, the future of how we approach babies who possibly or might have sepsis. This is a study called a nested case control study of babies more than 34 weeks gestation. She had about 350 babies with sepsis, early onset sepsis, meaning sepsis in the first 72 hours of life, and about 3 times that number of controls. And what she did differently, rather than using a cutoff value, saying prolonged rupture membranes more than 18 hours, she treated risk factors as continuous variables to try to provide an estimate of the risk for sepsis in a given baby. As it turns out, the 2 best predictive values were highest maternal temperature and gestational age, and she came up with a predictive model. And let me show what I mean by that. This slide is looking at incidence of early-onset sepsis expressed as cases per 1,000 live births versus gestational age. And if you took the black line represents the actual data, the red line is sort of the smoothed out data. And if you focus just on preterm babies, you would miss the babies who have gestational ages greater than 40 weeks, where the risk of sepsis starts to increase. The dotted line here indicates the baseline risk for sepsis. And the same thing is true for ruptured membranes. I said to you 18 hours is a sort of the focused time point for possible sepsis. And here you can see that the risk of sepsis with duration of ruptured membranes goes up clearly at 18 hours, but then when you get very prolonged ruptured membranes, the risk continues to increase. And treating it as a continuous variable allows you to interpret that. And finally, highest maternal temperature, the same story. Whether you pick 101, you can see the risk goes up a lot with 102 and even higher with 103 degrees. So she's come up with a little scoring system, and I hope this will be in your handouts, but this is a calculator where you can actually calculate the probability of sepsis. Again, looking at maternal risk factors in babies more than 34 weeks gestation. And her components are gestational age, temperature, ruptured membranes, groupie streptococcal status in the mother as positive, negative, or uncertain, maternal intrapartum treatment, whether it was broad spectrum or specific groupie streptococcus, and was it given at least 4 hours prior to delivery, and she then comes up with a predictive score. So let me show you an example. If the baby's 34 weeks and 5 days, the mother has a slight fever but not much, ruptured membranes for 12 hours, she's positive for groupie streptococcus, treatment was GBS specific given intrapartum and at least 4 hours prior to delivery. When you put it into her little calculator, it comes out to 0.8 per 1,000 live births, knowing that the baseline incidence of sepsis, at least in the US, is 1 to 2 per 1,000 live births. This tells you this baby's risk is no higher than baseline. And if the baby looks well to you, that might stop you from going through a long sepsis workup. And again, this is the beginning, I think, of other calculators that will be used to predict which babies are going to develop sepsis. Now, a great area of controversy is epidural anesthesia and how you interpret fever with an epidural. As I said, obstetricians often make that diagnosis in a woman who just has fever but no other clinical signs. But it's highly controversial. There's been several studies looking at cytokine determinations following epidural anesthesia, and interestingly, fetal cytokine levels go up in lots of those babies just from maternal epidural anesthesia, but it's unrelated to infection. Only about 11 to 33% of women developed a fever following an epidural. That's looking sort of at a general literature. Thus, most women who get an epidural will not develop fever. But the risk of having a fever in the epidural is shown over here with the confidence intervals over there. Epidurals can mask uterine tenderness, so it may mask signs of chorioamnionitis. On the other hand, some of the medications given with epidurals, like ephedrine or beta agonists, can cause fetal tachycardia, which can give you a false positive indication whether there's chorioamnionitis present or not. Most women with intrapartum fever elevation after an epidural have no evidence of infection. Fever appears to be more common, though, in women with histologic evidence of inflammation. So if there's histologic evidence of inflammation, 35% of the women got fever versus 17% who did not have histologic inflammation in the placenta, suggesting that in some women who get a fever, chorioamnionitis is part of the underlying mechanism. Unfortunately, a neonate born to a woman with fever is more likely to have a sepsis evaluation, and also fever during labor is a risk factor for having seizures of a non-infectious origin in the neonatal period. Well, our baby's now 1 hour old. The gestation rate is about 27 weeks. There's a little bit of respiratory distress, which is improving on CPAP. There's a history of groupie streptococcal infection in the mother with PPROM, preterm premature rupture membranes, for 22 hours. What testing is indicated at this time? So if this baby, I want to sort of get a show of hands, we're in your practice, 27 weeks, mild respiratory distress, history of GBS, how many of you would get a blood culture in that baby? If you could raise your, so it looks like about 137. I am a fast counter. White blood count and differential count? Yeah, I'd probably get that also. How many of you doing C-reactive proteins? Oh, a lot of you. I'm surprised. That's really. And I will talk just briefly about CRP. So the only fact you have to remember about blood cultures is it's the amount of blood you draw in the specimen that's critical. If you draw too little, you will not be able to diagnose sepsis. And the reason is about a quarter of all babies with bacteremia have what's called low colony count sepsis, in which case the colony forming units are about 4 CFU per ml or less. And then a more recent study have shown that between ages 0 and 2 months, colony counts are often less than 10 CFUs per ml. And in clinical practice, the amount of blood we get is often less. There was a great study where they followed interns around and said, I'd like you to draw a half an ml of blood for a blood culture. Intern would say, sure, and would do a venipuncture and draw the half an ml, and they push the air out of the syringe and out of the syringe, and what's left is about 0.15 mLs. We fool ourselves in the amount of blood that's sent for culture. And this is a great in vitro study done by a neonatologist now, Sri Lanka, in which he took blood specimens and inoculated them either with groupie streptococcus or E. coli at these 2 concentrations, 4 colony forming units per ml or 1 colony forming unit per ml, and then immediately took out a half, 1 or 2 mLs and asked the question, how often will I get back at least 1 bacteria? So if this is your original colony count, 4, and you take out a half an ml, you have about an 80% chance of getting a positive blood culture, which means you're going to be missing about 20% of the babies that actually are bacteremic. If you take out an ml, the odds go up to about 92%, 2 mLs, 99%. And if it's a very low colony count bacteremia, and you draw a half an ml, the numbers look even worse. 36% of getting a positive chance of getting a positive culture. With a half ml, with 1 ml, it's 60%. 2 mLs is 80%. So I try to have my residents to draw at least an ml when they send blood for culture. A long time ago, we did a culture by taking umbilical cord blood cultures at the time of birth and showed that they are rarely contaminated and they show a good correlation with postnatal blood cultures. And if you have an umbilical arterial line in place, it is okay to draw the blood culture through the umbilical arterial line. That is not true for umbilical venous lines. The importance of the volume of blood is illustrated in this study from Australia. It was really an educational intervention study where they tried to get the residents to take at least a half an ml for blood culture. And they were successful during that time. They went from 65% compliance to 82% compliance. But the take-home message for me out of the study published in 2007 is that blood cultures with an adequate volume, which meant at least a half an ml, were twice as likely to yield a positive result. So if you're drawing a blood culture, at least 1 ml ought to be your minimal volume that you obtain. So how about the ancillary laboratory studies, the white blood count, CRP? There are 4 characteristics of laboratory testing that you ought to be thinking about when you decide to order a test for sepsis. Sensitivity and specificity, positive and negative predictive accuracy. Sensitivity and specificity look at laboratory testing from the viewpoint of the laboratory test. Sensitivity is saying, if my test is positive, what's the likelihood my baby's infected? Specificity is saying just the opposite. If my baby looks healthy or is healthy, what's the likelihood my laboratory test is going to be normal? So sensitivity is looking at a sick population, specificity a healthy population. Positive and negative predictive accuracy tell you how to interpret the laboratory test. Positive predictive accuracy is saying, if my laboratory test is abnormal, what's the likelihood my baby's infected? Negative predictive accuracy is saying, if it's normal, what's the likelihood my baby is healthy? And in a perfect world, we'd like all 4 of these to be high. High sensitivity, specificity, positive and negative predictive accuracy. However, we all work in imperfect worlds. And the one characteristic that is most important for us as clinical practitioners is negative predictive accuracy. That is, the purpose of testing is to exclude infection in healthy babies, to prevent you from going through a long sepsis workup, or to stop antibiotics at the earliest possible time. That it'd be great if we had a test with a good positive predictive accuracy. We do not. Therefore, the reason we do testing is to exclude infection in healthy babies. Why do any laboratory tests at all? In a busy environment, when we say we have to observe this baby closely, that does not occur all the time. We all have lots of babies on our service. We may look at a baby at birth and come back 4 or 6 or 10 hours later. And we know from lots of studies that early onset sepsis occurs in babies that look totally well at the time of birth, that are initially completely asymptomatic. And tests with a high negative predictive accuracy will offer you reassurance that infection in that baby is unlikely. I'm not telling you not to examine the baby, but the lab tests will offer you reassurance that the baby is not infected. So this is looking at the predictive values of laboratory tests. Sensitivity, specificity, positive predictive accuracy, negative predictive accuracy. Looking at some of the various neutrophil indices which have been looked at, such as absolute neutrophil count, or the ratio between immature neutrophils and total neutrophils, or CRP or sepsis screen. Here are the positive predictive accuracies. In other words, these are the accuracies that would tell you that a baby's actually infected, and they're all terrible. Most of the positive predictive accuracies for any test you can name are less than 40%. They cannot tell you which babies are infected. On the other side of that, if you start and ask, what are the negative predictive accuracies, they're almost all terrific, varying from 95% up to, in one study, close to 100%. The two most commonly ordered tests are white blood count and C-reactive protein. As you know, we don't tend to look at total white counts. They're not very informative. Counts can be very high, normally up to 40,000. A very low count, which is defined as less than 5,000, should make you concerned about neutropenia. We tend to look at subcomponents of the white blood count, the absolute neutrophil count, the absolute band count, and the immature to total neutrophil ratio, which I've abbreviated I/T. The most sensitive indicator for infection appears to be the immature to total neutrophil ratio, and the most specific appears to be neutropenia because there's relatively few conditions in our NICUs which cause neutropenia. But none of the neutrophil indices, as I just showed you, have a good positive predictive accuracy. This is a cartoon from data from Barbara Monroe, who's down in Texas, from 30 years ago, from 1980, more than 30 years ago. And it's a cartoon because I don't want to give you absolute values, but it looks at the changes in those indices after birth. So the absolute neutrophil count rises and peaks at about 12 hours before falling off. The absolute band count follows a similar curve, and the I/T ratio starts off at its maximum value and then decreases. So what are the indices that I use for sepsis? Well, I look for an I/T ratio greater than 0.2. We could argue among ourselves. Some people might say 0.25 is a better cutoff value. I look for an absolute immature cell count or band count greater than 2,000. And I used to think I knew what neutropenia was, and all that's sort of changed in the past couple of years for me. First of all, I'm sure you know that infants delivered by cesarean section without labor tend to have lower total neutrophil counts. If you're like Bill Hay, you're going to hear later this afternoon, live in Denver, those babies have higher absolute neutrophil counts. And the lower limits of absolute neutrophil count do vary with gestational age. So our most immature babies, our VLBW babies, tend to have lower absolute neutrophil count. But the one fact I want you to remember about neutrophil counts is that counts obtained immediately after birth are frequently normal. Therefore, if you're concerned about sepsis, you want to get a count somewhere about 6 to 12 hours of life. It's going to be much more informative because it takes an inflammatory response in the baby to alter the white blood count. So unless sepsis is beginning in utero and the baby's already sick at the time of birth, it may take a number of hours for the white count or neutrophil indices to go up and down. To illustrate that well, I think, is this study by Tom Newman from California, study published in Pediatrics. And it looked at term babies and late preterm babies who were more than 34 weeks gestation, who had a blood culture and a CBC within 1 hour of each other. There was a lot of babies in this study, almost 250 babies, and about 67,000 control babies. And he looked at 3 time periods. He looked at the ability of the absolute neutrophil count and white blood count to discriminate the infected babies from the non-infected babies when you looked at the counts at 1 hour, 1 to 4 hours, or after age 4 hours. And to make it simple, these are receiver operator characteristic curves. They're called ROC curves. They look comparing sensitivity to specificity. And here it's looking at white blood counts, absolute neutrophil counts, I to T ratio, and platelet counts. The green on each of these curves represents samples drawn after 4 hours of life. And the area under the curve tells you which of those has the best sensitivity and specificity. So on every one of these curves, whether you look at total white blood count, absolute neutrophil count, the I to T ratio, or platelet count, the area under the green curve indicating the best sensitivity and specificity is best, again, for specimens drawn after 4 hours of life. So I try to get our residents not to draw a specimen, not to draw a white blood count at birth, but to wait 6 to 12 hours is what I tell them. There's been several studies looking at the lower limits, meaning looking for neutropenia at 6 to 12 hours of life. And I put them up here. There's studies by Monroe, Muzina, Skilanka, and Schmutz is the most recent study. But this is a study done at high altitude out in Utah. And taking all these data together, it's clear that more immature babies have lower values for absolute neutrophil counts. Bigger babies have higher minimum values. My definition, the one I've taken for neutropenia after age 6 hours, is less than 8,000 in a baby who's term or late preterm baby, and less than 2,200 at the other extreme for our preterm population. Now, a lot of you looked at C-reactive protein, or raised your hand and said you use that in your workup for sepsis. As you know, it's an acute phase reactant. It's synthesized pretty quickly, 6 to 8 hours of any infective episode, has a long half-life of 24 to 48 hours, and there's lots of data that the sensitivity of a CRP will improve if you don't get your specimen at birth, but you wait 6 to 12 hours. So again, if I'm using acute phase reactants, which we do at Columbia, I draw them at 6 to 12 hours when I'm getting my CBC. This is my cutoff value, a milligram per DL, or some people use 10 milligrams per liter. It has a very high negative predictive accuracy if you don't get a specimen at the time of birth, higher than 95%. It's not totally specific for infection. It's sensitive to inflammation, and CRPs go up with some non-infectious conditions. And they're slow to normalize in newborn babies. So you cannot follow the CRP and say, I've treated this baby adequately. So I'd like to show you 3 algorithms. And these are algorithms which have been published in an earlier form in pediatrics. We wrote a statement from Fetus and Newborn Committee on early-onset sepsis. And I'm going to show you the latest iterations, a small variation of them. And it takes into account the major risk factors for sepsis, which are prolonged rupture membranes for more than 18 hours, signs or symptoms of chorioamnionitis in the mother, and colonization with group B streptococcus, and knowing that GBS is not a risk factor if there's been adequate intrapartum treatment or if the infant is delivered by cesarean section with intact membranes and no labor. The other major risk factor is prematurity, and I'm going to show you a separate algorithm for prematurity. So this algorithm represents the majority of babies that you're probably going to be seeing in your practice. This is the algorithm for a baby who's 37 weeks or greater. I would tell you that it probably applies for a baby who's a late preterm baby also, but officially it's more than 37 weeks. But there's risk factors for sepsis, but there's not any evidence of chorioamnionitis in the mother. So the risk factors could be prolonged rupture membranes more than 18 hours, or intrapartum prophylaxis was indicated but inadequate. And here I believe you have 2 options. One option is these are big babies, you can do a careful physical examination, you just observe the baby and do nothing else. But again, observations are sometimes problematic. And if you're in a NICU where observations don't occur as frequently as you'd like, then the other alternative is doing a screening, is getting screening laboratory studies. For us, it would mean the white blood count and differential count. We would get a CRP, and those of you who can get it, I would suggest you do it. But we do not get it at the time of birth. We get it at 6 to 12 hours. We then observe the baby, and our management is, if the lab data are normal and the infant remains well, we'll discharge that baby by 48 hours and do nothing else, no blood culture. On the other hand, if the lab data are abnormal, you start to have a high I-to-T ratio or neutropenia. At that point, usually between 6 and 12 hours of life, knowing that some babies will become symptomatic later on, our recommendation is you get a blood culture. If the blood culture is negative, which is most babies, again, send the babies home by 48 hours. If the blood culture is positive, begin antibiotics. And in any, I'm going to talk about this in my next lecture, but any bacteremic baby, we would get a lumbar puncture to rule out meningitis in that baby. If there's a risk factor of 37 weeks gestation with chorioamnionitis, we take a much more aggressive approach because of the much higher risk of neonatal sepsis in babies born to women with chorioamnionitis. So we would get a blood culture at birth and do a sepsis screen at 6 to 12 hours, not at birth, and then begin broad spectrum antibiotics. These are asymptomatic babies now. Begin, for us, it's ampicillin, gentamicin. If our blood culture is positive, again, we're going to treat those babies for, I don't know, 7 or 10 days usually, and do a lumbar puncture to make sure no meningitis is present. If our blood culture is negative and the baby looks well and our lab data are normal, we try to discontinue antibiotics within 48 hours. So no babies whose cultures are negative in normal lab studies, even a 30-week gestation that looks well, will stop our antibiotics. However, in the situation where the mother received antibiotics during labor, we would continue the antibiotics even if the baby looks well for 48 to 72 hours because that mother got antibiotics. And again, stop them at 48 to 72 hours if the physical examination is normal. So maternal treatment is important to us, but no baby who's asymptomatic gets treated for longer than 72 hours. And in the preterm baby, our algorithm is almost the same. In the preterm baby, it doesn't matter to us what risk factor is present, whether it's chorio or prolonged rupture of membranes or inadequate prophylaxis. We get a blood culture at birth. We do a little screening CBC at 6 to 12 hours of life with our CRP. We treat those babies. If the culture is positive, we continue treatment and do a lumbar puncture. If the mother received antibiotics during labor and delivery, we continue antibiotics for a total of 72 hours and then discontinue them if the physical examination is normal. So even in a preterm baby whose cultures are negative, with abnormal laboratory data, we'll stop antibiotics. If the blood culture is negative and the baby remains well and the lab data are normal, we'll stop antibiotics at 48 hours. Which brings me to the topic of duration of antibiotic therapy. Whenever possible, try to discontinue antibiotics in an asymptomatic baby by 48 hours whose cultures are negative. In a critically ill, sick baby, then treating for 7 days, even with negative cultures, makes sense to me. There was a study out there from 2003 where they looked, at least in the US, duration of antibiotic therapy in babies with negative blood cultures. In the US, in this study, the average was 5 days, and there's the standard deviation over here. Treating babies for long periods of time can cause later morbidity. There's now 3 studies that are out there. The first of them was published by individuals at the NICHD Neonatal Network, where they looked at babies treated for more than 5 days, and they showed it was associated with an increased outcome of necrotizing enterocolitis or death. P-value was less than 0.01. NEC did not reach statistical significance, but mortality did. And this was a retrospective study of almost 4,000 extremely low birth weight babies. The same message is in this study from last year from Kurt Schibler's group, and they looked at duration of antibiotic therapy of 0 days, 1 to 4 days, or more than 5 days. And again, doing their multivariate analysis, more than 5 days was independently associated with the composite outcome of late onset sepsis, necrotizing enterocolitis, or death. after 7 days. And this study, published about the same time in Journal of Pediatrics, looks at the odds ratio for necrotized enterocolitis and relates it to duration of antibiotic therapy. And here's the curve going from 1 to 2 days up through 10 days. The longer you treat babies who are uninfected, the greater the risk of a later morbidity. And finally, just to end the case in this lecture, the blood culture was negative, and because of unremarkable laboratory values, the infant was only treated for 48 hours. As the infant grew up, he became a politician. You saw the earlier picture, and eventually became president of the United States. And here he is here, our former president, with one of his favorite words, which was nuclear. He could never say the words nuclear. This is something that George Bush said. And because I felt bad making fun of, well, a little bad, because I'm a Democrat, a little bad making fun of our former president, I did write to him and ask for a picture of him as a baby. I never expected to receive anything, but there he is as a newborn infant. He was not a good-looking baby, and for those of you who are in the first 3 rows, you can see I've transformed him from a male infant into a female infant. That's one of the problems in life. Thank you very much.